Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome John Mihal. He's a cardiothoracic surgeon and physician executive. His Kevin MD article is titled Three Myths About ECMO That Are Costing Patients and Hospitals. John, welcome to the show.
Oh, thank you, Kevin. I appreciate the opportunity to be here. Really excited about this. And thanks for all you do with your website and your podcast.
And thanks for coming on the show. And we'll talk about your article in a little bit. First off, briefly share your story and journey to where you are today.
Sure. Yeah, I've spent most of the last 25 years doing cardiac surgery and all that entails. But I've also had a lot of other experiences. I've been really involved in education and training. I started a symposium for cardiac surgery fellows. And then I also taught and proctored practicing surgeons on minimally invasive mitral valve techniques throughout my career. I led cardiothoracic surgery regionally for our health system for more than a decade, and then helped co-lead a national cardiovascular service line for a Catholic nonprofit health system. And this really gave me a lot of insights into some of the areas where health systems had needs. And I started a series of healthcare related service businesses, including a healthcare staffing business, which I later sold to Doximity, and then also a perfusion and ECMO services business, which gave me greater insight into the ECMO space. But it was really my clinical years when I had some pivotal patient experiences with ECMO that really drove my passion. There are obviously a lot of those patients, but a couple of them stand out. One was a young woman who, during the H1N1 pandemic, had not only respiratory symptoms, but also a viral cardiomyopathy and near constant ventricular fibrillation. And we were able to put her on ECMO, and she ultimately got better and survived. And the other one was a young baby boy, which was probably more poignant because I had a young infant son at the time. And we had done an arterial switch operation on the baby where the aorta and the pulmonary artery were in the wrong spots at birth, and we moved them to the right spots. But it was obviously a long and complicated operation. And at the end, there was just too much tension on the coronary arteries to get good flow. And we couldn't get the baby off bypass. And so we put the baby on ECMO for just a couple of days while the edema got better. And he went on to survive and get discharged. So some of these things really showed me the amazing power and ability of ECMO to, save lives and really change the course of patients who otherwise would have died.
So let's talk about your article. Now, to get everyone on the same page, ECMO stands for extracorporeal membrane oxygenation. So tell us a
That's
little bit about
correct.
that.
Yeah, so extracorporeal membrane oxygenation, and you're right, the acronym is ECMO. It's really just taking the blood out of the body, treating it where we oxygenate it, removing carbon dioxide, and then putting it back in. And so, in some ways, think of it as artificial lung, kind of like dialysis is artificial kidney. And it can either be done to support the lungs or to support the heart and lungs.
Great. And you wrote this Kevin MD article, Three Myths About ECMO That Are Costing Hospitals and Patients. Now tell us, how did your article come together?
The article came together really out of my realization of the magnitude of the missed opportunity to save lives with ECMO. Because the ECMO outcomes are now very good, yet too few patients are being treated with ECMO. And that really means that there's thousands of patients out there that could survive with ECMO, but they aren't really being given the chance. And when I look at the total possible population we could be treating, I personally think it's well over 1 million patients a year in the United States. That sounds like an awfully large number, but consider that we're putting over 4 million patients a year on a ventilator in the United States, and that's growing at over 20% a year. And roughly 20% of those patients on a ventilator are going to die. And that doesn't mean every single one of them is an ECMO candidate, but it's certainly a large number no matter how you slice it. There's over 500,000 patients a year that have cardiac arrest that show up in the emergency department, plus a bunch of patients who have cardiac arrest in the hospital that all could be ECMO and eCPR candidates. There's patients with unstable pulmonary embolism, cardiogenic shock. There's just a long list of growing indications. And when you think about that number of patients and the good outcomes we have, we really should be treating a much, much larger number of patients. And I think if we do that, we could be saving thousands of lives a year. So I've really got passionate about trying to increase awareness and patient access so we can start saving at least 1,000 lives a day.
So give us a sense of the context. So how often is ECMO used? Are they primarily used in academic medical centers in cities? Are they used in the community? Just give us a sense of the penetration so far.
Yeah. So we have a national database, and last year there are roughly 10,000 patients that could put into that database. So if you think of a possible treatment population of 1 million patients, that means we're treating roughly 1%. So that's a gigantic room for expansion. We may never actually treat 1 million patients, but even if we were treating 250,000, 500,000, 25, 50% of the potential patients, it's a exponential increase from where we are now. And I think to the other part of your question, where is it? It really is predominantly in academic medical centers and or large tertiary referral institutions. So of the thousands of hospitals in the United States, there's probably fewer than 100 that are doing this on a regular basis every day.
And tell us some of the indications for ECMO today.
Yeah, so historically it came out of respiratory failure, but it's really expanded beyond that. So it's still a great treatment for respiratory failure. And we've learned that the earlier we do it and the less injury we inflict upon the lung with the ventilator, then the better the outcomes are. But also for obviously times when there's both heart and lung failure, there's plenty of devices for heart failure alone, but not many for heart and lung failure. And the expanding indications are really around cardiac arrest, shock,
Mhm.
and resuscitation.
All right. So you talk about a few myths about ECMO today. So let's go into that. What are
Yeah.
some of the myths?
Well, when I started thinking about why do we not have greater penetration of this amazing technology, these are kind of some of the things that really came out as common themes. One is that ECMO is a drain on financial resources, i.e., the hospitals lose money doing it. The second was that it's too complex or too complicated. And the third is that the outcomes are poor. And when we really peel the onion and look at these things, none of them are really true. So the first one is that ECMO is a drain on financial resources. In reality, ECMO is the third highest reimbursed code from CMS. Only heart transplant and CAR T cell therapy are higher. And it's true that some hospitals are losing money on ECMO, but the reason for that is that they're not coding and billing it correctly. And the reason they're not coding and billing it correctly is because ECMO is an unbundled code. So there's very few unbundled codes, and very few people know how to appropriately clinically document, code, and bill that correctly. But when it's done correctly, the net contribution margin to the hospital should be well into the six figures, even for Medicaid and Medicare, and much higher for commercial insurance. So it's really a myth that you would lose money doing ECMO. The second is around complexity. And as you alluded to a moment ago, ECMO is very much like dialysis and other treatments where we take the patient's blood out
Hmm.
of their body, apply some therapy treatment to it, and then return it to their body. So if an ICU can do dialysis or plasmapheresis or veno ultrafiltration, they can do ECMO. It's really not fundamentally different. And the last really centers around outcomes. And like all medical technologies, ECMO was developed many, many years ago. And when we first applied it, we applied it to patients who are moribund and in compassionate use. And so obviously those patients are going to have a poor outcome. But as we've evolved our understanding of who to use it, when to use it, how to manage the circuit, how to manage the patient, et cetera, over the ensuing several decades, the outcomes are now very, very good. And over half of the patients, all comers, will survive when treated with ECMO. And if you take out the patients with underlying cardiac disease, over 70% of the patients are going to survive. And so if you think of a cohort of patients who almost certainly would have died without any treatment, these kind of numbers, two-thirds, 75% surviving, is really remarkable.
Now, what do you see as the biggest barrier that needs to be overcome in order to have that wider adoption of ECMO?
It's a couple things. One is the awareness issue. So I think the myths that we just alluded to are pervasive. We have to debunk them. We're trying to do that. The other is going to be training and education and getting the knowledge out there on how to do this. Dialysis is a unique subset of skills. All these things are unique subset of skills. And, competent nursing staff and clinicians can manage any of these skills. They just have to be taught. So I think those are the two big barriers right there.
So, from a physician standpoint, what kind of training needs to be involved to learn how to manage ECMO patients?
Yeah, fortunately, a lot of fellows that are being trained today are being trained on ECMO because of its presence in the academic centers. And they're going out into community hospitals. And a lot of community hospitals are actually realizing that they're having trouble recruiting if they don't have an ECMO program. So the barriers around physician training, I think, in some ways are being addressed by the training programs, but the education of physicians who are already out into practice, that I think that's a very easy skill for them to master. They just need to be given the opportunity. And then there's also really, this is a team sport. It takes more than the physician deciding they want to do it. They really have to get buy-in from the whole intensive care team, and then the nurses and the other folks involved in that also have to be educated.
And then, from a nursing standpoint or support staff standpoint, what kind of additional training is needed to manage ECMO?
So typically there is some nurse specific education, but the nurses themselves are not managing the ECMO circuit. There's usually an ECMO specialist, and those folks either have a RN or RT or perfusion background, and then they are trained in the ECMO part of it. That particular training for nurses, respiratory therapists, and perfusionists who have critical care experiences is not a large lift for them. And then they would manage the ECMO circuit for either one or up to several patients, depending on the acuity of those patients.
So any downsides to ECMO that as compared to just the traditional ventilator?
Yeah, that's a great question. I think the downsides are very similar to a traditional ventilator in that you really want to select carefully the patients that you apply the therapy to. And just like with a traditional ventilator, you can put somebody on a ventilator or you can put somebody on ECMO only to find out that there's really no getting off of the ventilator, getting off of ECMO. And so you want to carefully select patients who have recoverable conditions, who are neurologically intact, et cetera, so that you don't end up in a scenario where you're simply prolonging the inevitable. But other than that, this is a therapy that can be done by many, many hospitals and could really truly save many lives that are not being treated now.
So tell us, what do you see as the path forward in the foreseeable future?
I think really we're working down that path, and the path is, making people more aware. And I think the awareness is growing. We saw during the COVID pandemic that there were literally hundreds of families who had loved ones that were dying on a ventilator at a hospital without ECMO, and they were calling ECMO centers and ECMO providers trying to get those patients transferred, and the centers didn't have the capacity to treat them. But it reflected that there is awareness around that. There's also organizations out there such as Marie's Miracle and others that are really putting these success stories out and trying to grow awareness and access. And as those stories get out into the mainstream media, it's growing that core awareness. And I think there's a little bit of a lack of awareness on the provider side about the outcomes and the ease of doing it. And I think those are the things that will eventually, I think those barriers are getting broken down and it will expand the access.
We're talking to John Mehal. He's a cardiothoracic surgeon and physician executive. His Kevin MD article is titled Three Myths About ECMO That Are Costing Patients and Hospitals. John, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Yeah, thank you. I think the number one is that ECMO saves lives, period. Whenever you have a patient with respiratory failure, cardiac failure, shock, think of ECMO as throwing them a lifeline, not as throwing in the towel. I think the paradigm has shifted on that. That's the biggest one for the providers for sure. And I think the other thing is that this is not too complex. If your nursing staff can do it, your ICUs can do it. In many ways, it is a recruitment and a retention tool. It gives additional clinical ladder opportunities for your nursing staff. And lastly, there is no financial barrier to this. When done correctly, this should actually be a positive for the hospital in terms of their financial performance.
John, thank you so much for sharing your time and insight. Thanks again for being on the show.
It was my pleasure. Thanks for having me, Kevin.